He is a neurologist who works in the surgical movement disorders group. He trained at USC, and then I think he did a fellowship partly here and partly in Pennsylvania before settling here. He is interested also in telecommunications or telemedicine, I think is probably the best word. And some of you may actually be taking part in studies in which telemedicine is involved. He is the PI for those studies here at UCSF. He's going to be talking to us today about emerging technologies in the management of Parkinson's. Again, my apologies, Dr. G.
Thank you, everybody. Thanks for having me tonight. It's really great to see a lot of familiar faces here. I'm going to talk about emerging technologies in the management of Parkinson's, and so this won't, be a long talk about genetic technologies that are rapidly advancing, or some of the pharmaceutical things that are rapidly advancing. So it's more about applications of tech to Parkinson's management. And so first, especially for the first several years of my career here, and still ongoing, I work in the Surgical Movement Disorders Center, where the main thing we do there is deep brain stimulation, evaluation of patients, and the post-operative programming. So we're going to talk about recent advances in the DBS field. Then I'll talk a little bit, as Tucker Eminoff mentioned, about telehealth and how, in different ways, telehealth applications can help in Parkinson's management. Oh, sure. Yeah. And so we'll talk a little bit about recent advances in deep brain stimulation. Then I'll talk about my recent interests in telehealth and how telehealth applications can help Parkinson's disease management. And then a little bit at the end, seeing how much time we have, we'll talk about some of the wearable technologies, including, you can't give a talk in San Francisco these days without talking about smartphone apps and so forth, and then how those data can be applied in big data information processing. So in DBS, so a lot of you here know, but just as a quick review, deep brain stimulation is a way of delivering therapy to very specific targets in the brain that can modulate the symptoms of Parkinson's. And so as you can see here, maybe not, yeah. So you have a pacemaker in the chest wall with the wires that come up, to under the scalp, and then there's a burr hole in the skull that lets you gain access to the brain. And then the hard part of the surgical technique is getting those electrodes to the right spot within millimeters, really 1 millimeter accuracy, because the location, just like real estate location is the key. And so by delivering current to those spots, it's really, in some ways, is imitating effectively levodopa physiologically. In other words, the downstream effects of applying stimulation at that spot in the brain mimics the downstream physiologic effects of dopamine in some ways, not completely. A very, very common question patients have for us is there a DBS window? I bring that up today just because it'll have implications for some of the new technologies out there. So we rephrase that question in terms of who is a good candidate and who might deep brain stimulation be a little too risky for. So I guess it makes us seem what I do is not too complicated, but we really have 4 main points where we make sure who is a good DBS candidate. So first of all, it has to be very clear that the patient has Parkinson's disease. That sounds straightforward enough, but as I'm sure some people in this room have been through, it's not always so straightforward. And that there's a good response to medications. So if levodopa is not helping, it's unlikely that deep brain stimulation will help either, with a few exceptions like tremor. Now, the next question everybody asks is if medications are working, then why do you need DBS? But the key is that they might be optimized as to the degree that you can, but you still are struggling with disabling symptoms, whether it's the meds are not reliable, they wear off too soon, they cause dyskinesia, and so forth. Next, people have to be healthy enough for a general surgery or having surgery in the brain. So there are certain things like having to have blood thinners on board or other things that might preclude people. And then cognitively, behaviorally, people have to be stable and not too advanced because we don't want to make people worse. So some people with some, maybe moving out of the mild cognitive into moderate cognitive impairment, we don't. Those patients are more susceptible to the effects of stimulation and having intracranial surgery. So we obviously don't want to make people worse. So, and then lastly, and this is probably the most complicated thing, is that the chief complaints and the disabling features and most bothersome features for the patients are, we have to make sure that those match with what we have a chance of helping. Because if a patient wants to come in and have their dementia fixed or their imbalance or urinary function, we will not help those things. DBS is very good at helping tremor, dyskinesia, the motor fluctuations, so really movement issues. So how does it work? The quick answer is that we don't know completely. There's an evolving science and theories about how DBS works. I won't go into detail about the rate model and the oscillation model and different parts of the brain that start firing together that leads to the abnormal symptoms of Parkinson's. Phase amplitude coupling is something that's been discovered in Dr. Starr's lab here at UCSF, and we'll talk about in a second how that's going to apply to potentially emerging technologies. So again, when does DBS work? It's really about having a good candidate, as we talked about above, location of the electrode, so we'll talk about that, and then good programming and being able, when side effects come up, whether it's tight speech or some of the behavioral side effects that come up from stimulation, and then hardware complications. So a couple of those we're going to talk about how newer developments in DBS might improve those problems. So just a quick history. Dr. Benavide in Grenoble, France, 1993 was the first person to use subthalamic nucleus deep brain stimulation in Parkinson's disease. It was eventually approved for essential tremor in 1997 and Parkinson's in 2002. So, and people were being implanted in the mid-90s or late 90s at least for Parkinson's as well. So it's really been around for going on 20 years. And in those 20 years, about over 100,000 people have been implanted worldwide. I think UCSF has about a couple percent of that. Certainly over 1,000, I think approaching 2,000 since they first opened the center 15 years ago. And now Medtronic has been the main company making these stimulators for the last 2 decades, but in the last few years there have been new companies coming up with their own products, and the Medtronic products are really great, but it's nice to have other competition to hopefully drive innovation. So that's been a welcome addition. So first I'm going to talk about the recent developments in DBS, and so I came here in 2008 when we still had the first or second generation stimulators, which is I don't know if I took it off there, the Soletra and the Kinetra made by Medtronic. And since then, the third generation has come out in 2009, where it gave us a couple more possibilities of improving the stimulation parameters. So first of all, a somewhat basic one was going from this constant voltage to constant current. And I don't know if anybody remembers from high school physics or college physics, the difference between the two, but voltage will fluctuate as the resistance fluctuates, and so there are resistance changes that can change in the brain hour to hour and certainly over time at the location of the electrode. So constant current, and current is what we really want to be able to titrate, so there's theoretically at least constant current might be better, so that's available on the new devices. Batteries have also improved over the years. The Medtronic batteries are initially the ones that you just implant and then they wear out and you have to replace them. They last between 2 or 3 or 5 years. Medtronic has rechargeable batteries that can last up to 9 years. And the new Boston Scientific devices, they're brand new, so this is yet to be shown for real, but they have different technology in the battery that potentially could last over decades. Another big, so you can understand definitely how better batteries would be good. You can do more things with the stem. You can not have to have battery replacements every couple of years. And the batteries are also getting smaller and smaller, so they're better tolerated, not causing as much of a lump in the chest. Probably a bigger deal for every day, what we try to do in terms of programming is the shape of the electrical field that is produced. So you can imagine that, let's see here. So this is maybe a good example of the first way that it was always done. You have these several electrodes here, and this is like cross-section of the lead, so you're kind of looking down the lead. So every device available at this point is you stimulate through that electrode, it goes in all directions around, and you basically have a spheroid kind of shape of area of stimulation, which really for most patients does a good job, but sometimes you want to use other electrodes as well, and you might want only so much here, but more here, or vice versa. So the third generation devices created this thing called interleaving. So you could have two programs set up in the same electrode, and they would literally switch back and forth between which one fires at about 120 times a second. So in effect, you're delivering stim to these two areas at different frequencies. And again, this is kind of showing the anatomy around where the lead's going, and every little half millimeter or even less, really can be a difference in side effects or therapeutic. So it doesn't seem like a huge advance, but it's like there's many situations where we do want to have like less up here or more down here, or vice versa. So that's what we call interleaving. It's just two programs flickering between each other very rapidly. So the new Boston Scientific devices take that. So the problem with this is that, and actually there's been formalized warnings and so forth, that this drains the battery very quickly. So we've been really trying to, unless we can really prove that it's meaningfully better for our patients in terms of using this versus the more standard thing, it'll really drain the battery quick. So the new Boston Scientific devices has these things called MICC, or multiple independent current control. They also have 8 spots where you can titrate it out, not just 4. And so you can deliver all kinds of different, you can set the charge for the whole lead and then break it up percentage-wise, how you see fit. Maybe you want a lot up here, just a little tiny bit here. And there's various physiologic, real anatomic reasons why you want to do that. For instance, the classic one, which might be what they're trying to show here, is that the deep electrode you might want really in the heart of the STN nucleus, which is the main anti-Parkinsonian effect. And the higher up ones, maybe a couple millimeters up, are in this different area, actually just right above the STN, which we think is useful for anti-tremor and anti-dyskinesia effect. So this kind of lets you, again, distribute along this z-axis. If it's like x, y, and then z is like kind of your height. But the other big issue is the x and y axis, so like cutting across this way. This is important because running right next to the STN and the GPI on the other side is the main highway that carries all the motor information from the brain down to the body. So if you overstimulate that, and I'm sure some people in this room have experienced this, where you get what we call the fish hook, where your face gets pulled, or tightness in the arm or the leg, and we obviously want to avoid that. Or even if it's more subtle, changes in speech. So in other words, here's your STN, and going down the side here is that superhighway of axons that carry that information. So you might want to just deliver the stim one way but not the other. So I think St. Jude has a device you can steer the stim. So you, instead of going in a circle around it like in these are showing, you can you basically block one side and just let it focus on one direction. And so that actually there's many times when we run into this issue where to get the therapeutic effect of the stim, we're having these side effects tickling that separate area that we don't want to stimulate. So when this becomes available, this will be a nice advance. And then there's other companies, actually it's a European company, I can't remember the name of, that instead of doing this thing where they shield one side, they just have multiple contacts on all sides that you could stimulate. So, and that's, to my knowledge, that's not available. So what that brings up, oh, well, and we'll talk about that a little bit later too. So one of the things we talked about before is being able to better target, because location is everything. So for instance, the STN is only a few millimeters wide. So if we end up too much to the lateral side of it, you're going to get close to that highway of neurons, and so a millimeter really can make a difference. And so, as some of you may know, the standard technique is to be awake for surgery, because the surgeons use the pre-op scan images to plan where we're going to go with the electrode, and that has been quite accurate. But really, once you're in, you're blind to where the electrode's going. And so we use a combination of that preoperative planning, physiologic, literally listening to the electrical activities of cells as we go deeper into the brain until you get to the right spot. And then once you're at the right spot, you can literally turn on the device and see if it helps the tremor and so forth right there in the operating room. But sometimes if you don't hear the right cells, you have to come back out and poke again, and you can imagine anybody in this room would want your brain poked as few times as possible. So actually, this new technique, now not so new, the last 3 or 4, 5 years ago, was developed here at UCSF by Drs. Stone Larson, the surgeons here, and Alistair Martin. So it's the interventional MRI technique, which allows real-time visualization of the electrode as it goes to the target that you planned out beforehand. So you can really see, so this is some of the apparatus. This is all done in the MRI. So you can't have any ferromagnetic metal, so a lot of them is plastic components. But you literally can plan this trajectory through, there's these grids that go on the scalp, and you pick which one, and you can line it up and go to the right spot. And then intraoperatively, the lead comes down, and again, you can see it the whole time until you get to the spot that you want to be at. And then this is, I think, post-op imaging that shows that they got it at the right place that they want it. So again, you can see it the whole time. We have sub-millimetric accuracy, so literally the standard radial error, how many millimeters we were off from the expected target, is under a millimeter, almost half a millimeter. Whereas the standard awake technique is more like 1.2, 1.3 millimeters, so it's doubly as accurate as the old method. We haven't shown that that's clinically superior in terms of getting better outcomes, but certainly just as good in terms of once it's implanted and the effects of stimulation. However, again, like we said, you can imagine how I think everybody would want less lead pokes through the frontal cortex here to get to the target. And in the trial that we just is in publication right now, and which was both STN and GPI targets, every single one of those leads, which is over 50 leads, was implanted on the first pass. So only, except for one. So one electrode had to be taken out and retried again. So that's unheard of in standard awake technique. I think the average is more like 1.5 to 2 tries for every lead. So cutting that down in half. And sometimes it's more than that, like 3 or 4. So those are things that are available now, as we mentioned, except for maybe that directional steering of the current. But there will be, hopefully, things that will represent the next generation of DBS devices, and people, Dr. Starr in his lab, as we mentioned, and others are working on that realm as well. So, and the idea there is adaptive stimulation. So really what we do now, if you really think about it, is a little bit crude. We turn on a battery and it delivers current, and it's just always on. And sometimes when your meds wear off, you can imagine you need more, and then when they're working well, you need less, and you could avoid some of the dyskinesia that meds and dyskinesia sometimes can pile on each. Meds and stimulations can sometimes pile up and cause more dyskinesia. Thankfully, it's not so common, but so an adaptive system that kind of has we call it closed loop stimulation, because you're not just delivering stim, you're also you're gaining some signal from the brain that then tells you that you need to modulate the signal. So this is real life in cardiology and even in epilepsy. There's devices that can sense a seizure coming and then say, okay, we need to do something to block it from becoming a full-blown seizure. Definitely cardiac, implanted defibrillators and things do just that as well. So the hard part is finding what is the signal that you can read and then be able to do something about. And there's 5, 6 plus competing ideas out there. What Dr. Starr and his lab have proposed is phased amplitude coupling, and we'll go into that in detail, but there's cortical electrodes here that are sensing what's going on in the cortex at the top of the brain, and then you obviously deliver the stim in the deep brain, and we hypothesize a signal here that can tell, you send a signal to the stimulator and back, they deliver a constantly self-adjusting level of stimulation. So, and in other models at other centers, and actually now there's a way to do this here as well. Again, very experimental, not close to being widely available, but there are proof of principle studies and experiments that have worked. So again, we talked about that implantable sensors. Again, the real-time modulating of that stimulation is not a reality right now, but the sensors implanted in the brain, just like this showed right here, which Dr. Starr was the first to do, is a reality. And so we call that, actually that's unique to him, but the new Medtronic has a device called the Activa PC Plus S, and the Plus S is sensing, so they can not only deliver stimulation through the lead, but also gain a signal from the brain. Dr. Starr's group has combined it with this cortical grid to make it even stronger. Other people call it the brain radio because you're listening to the brain. So that's kind of, you can imagine other sensors, other places that might be able to, again, help the stimulation parameters. With all these things, you saw that electrode, I don't even know how many, I think it's something like 56 spots. What we work with in practice now is either 4 or 8 electrodes we can stimulate through, but I don't even know how we would address this with combining that number of electrodes with the frequency and pulse width and everything that you can do. There's literally millions and millions of permutations and combinations that you could do. So up until now, having a rational approach of, okay, we test each lead, we see which one works the best, which one causes side effects, tailor the stim to then the effects on the patient. That's worked. It's already complex enough, but you can imagine how when you have millions and millions of possibilities, it's not a feasible thing going forward, especially if you have other things. So basically, so I think the newer people are some people thinking about these things in terms of computer modeling of what should be done, basically taking in imaging findings of exactly where you are in the anatomy, and which type of axons or thing, and really just gets very, very complicated. But so the idea would be to move to automated guiding of programming, but that's pretty far off. For instance, Cameron McIntyre in Case Western in Ohio is doing some of this computer modeling with really specific tracks in the brain and so forth. And again, you can imagine if you're really being that specific, it's less battery drain, it's less chance of overstimulating patient. Actually, one of the studies he did was showing that really the stimulation parameters we're using are probably overstimulating our patients, and so less cognitive side effects and so forth potentially. So I'm going to move on to another interest of mine in terms of research, which is telehealth. Especially in the last few years, I have, since I came here now 7 years ago, I've been doing telehealth at the VA especially. The VA has a great technology infrastructure that allows this. We also get around some of the barriers of telehealth that we'll discuss. But basically, telehealth is using technology, communication technology, to deliver services remotely. The most common thing people think of is this two-way live, almost like a Skype, to talk to your patient. At the VA initially, we were doing clinic to clinic. Again, most VA clinics are built with these capabilities. But now we've also been doing video to home, or the virtual house call, so that the big idea here is that house calls are coming back. There's other forms as well, just asynchronous, which means we're actually involved in a project in Nigeria where a local neurologist there is recording videos, uploading it to a server, and we can do a video examination and send back her opinions. That's been standard of care in radiology and dermatology for a while. Obviously, they're very visual. And there's other things like smartphone apps and other smartphone technologies. Dr. Kosa mentioned some of this remote monitoring that's possible in a patient's home. I think the idea of really seeing that when somebody's moving less and then predicting that maybe they're not doing as well, and your doctor can tell that right away and give you a call and see what's going on is really amazing. There's actually a field of telemedicine called telecare, where the whole focus is to try to keep people in their homes independent and safe for as long as possible and avoid nursing homes. There's other things as well. Right now, up until the last few years, if you look up telemedicine neurology, I think 80% comes up as stroke, and there's various reasons for that. But I think with Ray Dorsey, but previously at Johns Hopkins, now at Rochester, really pushing the field forward, Parkinson's has probably jumped up to number 2 in the use of telemedicine. So the idea here is to improve access. Obviously it doesn't take too much imagination to realize if somebody lives way up in Eureka or something, it would be great to just be able to press a button and talk to your doctor immediately. Obviously, patients with neurologic conditions, travel can be an extreme hardship sometimes. And then problems with cognition and strange surroundings and being in a hotel, and those all things can exacerbate cognitive problems. And not to mention all the time off work of caregivers and so forth, and expense as well. And the idea, obviously, is that you get better access for people that would otherwise be hard to get to their doctor. And you can see a Parkinson's specialist as opposed to a general neurologist in some of these areas, and hopefully that would be better care. There's actually evidence for that, and then cost efficiency, and not to mention, obviously, patient comfort and satisfaction being in their own home. So there are major challenges, and some of these are getting worked on and improving. Financially, it's hard to do things in the modern setting in America with if it can't be paid for, then it's difficult. And unfortunately, in California, actually, private insurers and Medi-Cal are mandated to pay for telemedicine services in people's homes, which is great. But Medicare is not under that, and so Medicare obviously is a majority of our patients, and so we're hoping that changes. Of note, UCSF, I think last year, recognizing that this is what patients want and this is the future, made it so that even if Medicare does not reimburse, they're going to cover the RVU for the physician so that we can still use our time to provide that service. Obviously, there's problems going across state lines, which really, California being such a huge state, it's less of an issue here, but you can imagine in North Dakota or something where it'd be great if you could see somebody at Mayo Clinic in Minnesota, but if they're not licensed in North Dakota, you can't do it. So there's advances there, technology. Obviously, some would argue that what kind of doctor-patient relationship can you have through a computer? But actually, there's some really good studies that should actually people feel like that what has been termed the veil of technology and being in your own home actually lets you be more open and comfortable. But so PD, obviously, again, it's a chronic progressive condition which is constantly changing, so you need to have frequent visits to modulate the meds and other things. And we have good treatments that can make a difference if you see your doctor. So, yeah. And almost our entire exam is visual, so we can do almost everything we need to do. The symptoms are manageable through history. And again, the problem that most Parkinson's specialists are in major metropolitan areas. So this is the key thing here. I think the idea is to flip the paradigm. This is a study done by Ray Dorsey, published a couple of years ago, where the total time door-to-door in-person visit was like 250 minutes on average for this, I think, upstate New York and Maryland population, where 22% of that time was spent with the physician, 78% was traveling or being in the waiting room. Whereas on just literally turning on your computer and hooking up and getting to see you just completely flip this to the majority of time being spent with your physician. And I'll skip this. This is just some of the comments in the qualitative study part of this in terms of what people said. I think not having to drive 2 hours and then, my wife missing an entire work day and having access to a movement specialist and just being able the veil of technology, that was where that quote came from. We're involved, as Dr. Amanoff mentioned, on the 2 largest telemedicine for Parkinson's trials here at UCSF. One of them is a randomized trial, so we can really compare its efficacy to usual care. The other one is just more of a showing that on a nationwide basis this can be done. This would have, you can imagine how in the advanced stages of Parkinson's, where mobility and cognition and other things become even more difficult, travel becomes even more difficult, and so forth. So those benefits of telemedicine need to become more so. So we're also involved in two palliative care, one palliative care study and hopefully a second. The first one, we're going to be able to do some of the study visits via telemedicine, so patients can participate in clinical trials from their home. And the second one, actually, our piece is, if we get the funding, will be almost completely telemedicine. So they'll go to their local neurologists who will get some palliative care and supportive care training, but anytime they need to see our multidisciplinary team, they'll just from their home dial in straight to us. And there have been examples of things like tele-rehab and voice therapy and cognitive behavioral therapy and the home monitoring that have been already shown. Let's skip this. I talked a little bit about the experience of the VA. Actually, what inspired me to get into this was in the span of a month, the San Francisco VA has a catchment area that stretches up to Minnesota and Michigan. And I had two patients fly from Detroit and Ann Arbor to 2,500 miles to see us, and it was really obvious within minutes that they weren't a deep brain stimulation candidate. And you can understand how angered and frustrated they were of the expense of travel and everything. And actually one of the patients, again, understandably very angry and frustrated, actually had to call security because it was threatening. So that was kind of my inspiration of realizing how this can be used. And after that, we converted all out-of-state evaluations to telemedicine first. And then if they are a reasonable candidate, then you can bring them out. And for our palliative care, supportive care clinic at the VA, we've been doing video to home visits for the last 5-6 years. So I don't know if we're going to have any time to. I have 3 minutes, so if that's correct. But I'm going to talk about some of the wearables that they've kind of been hinted at already. I won't be able to go into more detail, but things that you wear on your wrists and your shoes, a cell phone. I actually have a couple apps on my phone to kind of test these out, where it's just monitoring things, almost like the pedometer apps that I'm sure some of you have seen. But really what the hope here is that it'll give more sensitive outcomes, more objective outcomes, and continuous outcomes, literally 24/7 remotely. It's also, this is our usual, testing muscle tone and having you do, I'm sure everybody's done those tests many times. Those are great and very well validated. There's nothing wrong with this, but in terms of research and clinical data gathering, more continuous, objective, multidimensional, having the accelerometers, gyroscopes, GPS on your phone can really make a huge amount of data that could be analyzed with machine learning and things like that is what people are thinking of. And I already hinted at the use in possible clinical trials. One of the biggest problems with Parkinson's clinical trials is how hard it is to recruit people coming from such long distances. Every trial we do for deep brain stimulation, everything else, we have to say, okay, you live in Sacramento or Reading, and are you going to be able to make all those visits? And so this is hopefully going to be something here. And of course, there's all the apps like I mentioned. The biggest one is Empower, which is the largest clinical trial in Parkinson's ever. 15,000 people signed on in the first month. And there's other things. I actually use this one in clinic. I literally give patients my phone and have them hold the thing. I can measure the frequency and amplitude of the tremor and kind of keep track of it. It's not anything revolutionary that has been major changing management, but Parkinson's and essential tremor have different frequency of tremor, so you can investigate that. You can also see if the tremor is getting, the amplitude of it is getting smaller and things like that. And that similar technology is in the Lift Spoon and so forth. So thank you.